Good day, everyone. We are gonna have our next case-based scenarios discussion at the ESTM webinar series. I think this will be an exciting discussion. The topic today is temporal lobe epilepsy with normal MRI. There are lots of technical issues going on. There are lots of pre-op evaluation issues taking on. So I think we are gonna be able to have a lively discussions, and we have two outstanding presenters today, Samir Sheth and Chima Oluigbo. And what we are going to be doing, let's see their presentations first and then go for discussion. We are going to start then with Chima. Chima, would you please share the screen and present your discussion? Thank you so much.
Great. Thank you so much. Thanks, Arthur and Guy, Jorge, Bertil, and Christian. Thanks so much for this invitation. Good morning or afternoon, ladies and gentlemen. So my presentation will be a case-based scenario. I'm discussing surgical treatment of temporal lobe epilepsy in a patient with a normal brain MRI scan. I have a disclosure. My first disclosure is that I'm discussing an adult patient. So a large volume, most of my cases, epilepsy cases, are pediatric. I probably do about certainly more than 90% pediatric epilepsy. I do a small number, about 5 to 10% adults sent from George Washington University Hospital. But you know what? I actually did look at all my data for the relatively large volumes I do of pediatric epilepsy surgery. And it's actually very rare to see a pure pediatric temporal lobe epilepsy without MRI findings. It's actually pretty rare. I'm not talking about a multi-lobar, maybe temporal occipital, or multi-lobar, but isolated temporal. And so I had to go for an adult patient who I treated not too long ago. Now, it's not just me, actually. I had to do a quick search in the data, and I looked at people like Schramm. I mean, Schramm is a heavy hitter in this area, and he had about 183 pediatric temporal lobe epilepsy patients. Huge, that's a relatively big number. And I wanted to see what proportion had no structural MRI findings. And it's just 4%. So only 4% in that big number. And so that's interesting. Later at the end of this talk, I will tell you our thoughts as to why you rarely see this in pediatrics. There are functional network reasons why that happens, but that's for later. Let's go into the case. So this patient is a 35-year-old right-handed male with refractory focal epilepsy. No personal or family histories. Doing well, but seizures started when he was 20 years old. He was started on valproate, and he had good control of his seizures for 3 years until he came back. He's originally from Australia, and while he was at Melbourne, he had video EEG that captured electrographic and electroclinical seizures from the right temporal area. He was started on 3 medications. They added clobazam and kept her to his medications, and that's at the point in which I saw him, where he was beginning to have some cognitive impact and word-finding difficulties. Now, his seizure semiology is critical to the understanding of how we approach this case. So he had different types of seizures. He had a nocturnal type seizure where he was stiffened at night with impaired awareness. His wife reports that this happens every night, lasts about a minute, doesn't recall the events. He has another type of seizure when he's awake, and he reports this, he reports a pulse that's surging through his body, gets very strong, and he gets this vasomotor response as if he's going into fight or flight mode. The third type of seizures he recalls, well, more like an aura. He'll have a deja vu sensation. He will retain awareness. This happens maybe once every few weeks. And he has intact receptive and expressive speech with intact awareness. Medications, as I discussed, examination was essentially unremarkable. So I told you about his investigation in Melbourne, Australia, seizures arising from the right temporal area. And he did have EMU admission under us. We captured the different types of seizures he had. And this first one. Seizure starts at this point, mainly T4, T6, and the seizures start to evolve from that point. Seizures now evolve. Now, he awakes later. He makes comments. He awakes later, and I'm just going to fast forward to this point when the nurse comes and he's describing, and you see he's describing to the nurse what he feels. It begins to show that gesture is making is that it's like on a roller coaster, it's rolling, it can't stop, and he gets into fight or flight response. And he says he feels a pulse surging through and goes into fight or flight mode. We also captured the other type of seizure where he just has, just more or less just an arousal. This is the nocturnal seizures he has at night. Just, slight arousal. Then, he goes back to sleep. And this seizure is actually, once again, this is a T4, T6 type onset on the seizure. Now, MRI scan was unremarkable. I'm just going to scroll through quickly. You could argue some atrophy for a 35-year-old, but this guy is a very, very high functioning IT specialist, very high functioning. So that was not really relevant to our findings. We went ahead and did a PET scan, and the PET scan once again pointed to the right temporal region. I'm just going to, pause here. You begin to see already a right temporal. There's a hypometabolism in that right temporal region compared to the left side, which, radiologists agreed with that. fMRI scans show that it's heavily left hemisphere dominant for language. So that was pretty clear in this case. So let's look at the summary. So we have this 35-year-old man. Semiology localization suggests temporal or limbic. Interictal's ictal EEG points to temporal on the right. We did a Curry, I didn't have the results here, but pointed to right anterior temporal. MRI is non-lesional. PET scan points temporal, likely right. fMRI left hemisphere dominant. So I think that brings us to the next steps. And feel free to chime in. I mean, the next steps are all our phase 1 investigations point consistently to a right temporal lobe seizure. Know what people's thoughts are. Is this the sole thing? One will say, well, there's this points right temporal. We're going for a right temporal lobectomy. Or do people feel that this requires invasive intracranial monitoring? And if you're doing that, you're doing a stereo EEG using subdural grids or strip electrodes. Okay. So I'm just going to go ahead and say what we did. So we went ahead and did the stereo EEG. Our objective in stereo EEG is the seizures. These were temporal seizures, but there was a bit about the seizures that were beyond temporal, right? Some of the nocturnal presentation. We also felt there was some vasomotor aspect to seizures, that fight or flight response. And so we felt we should cover the temporal lobe, frontal lobe, also the insular, and those were our thoughts that we definitely had to cover those. Maybe a question of a discussion is, will people think about covering the contralateral left hemisphere? Our view was that everything in our phase 1 study consistently pointed to a right hemispheric onset for the seizures. And our feeling was that we could not justify the extra risk in placing depth electrodes on the contralateral left hemisphere. And we felt we'll get better diagnostic yield on focusing our implants on that right hemisphere. And so went ahead, placed 13 depth electrodes, right hemispheric, 124 contacts. And basically, these are the locations of our contacts. We had about 4 contacts in insular. We covered the mesiotemporal structures, hippocampus, amygdala. We had temporal pole, good mesial frontal and orbital frontal coverage as well, to better understand and delineate this the semiology for this patient's seizure. So I just cut straight to the page in which patient's seizure started. His classic seizure, with the vasomotor and deja vu sensation, and the areas we see high voltage poly spike wave activities in this areas. These areas are, and I'll show you on the next slide where they are. Essentially, we have MTA is middle temporal to amygdala, but these are superficial contacts. They're actually not. So these are neocortical temporal lobe targets. SFM is superior frontal to middle insular. 5 and 6 is right on the upper aspects of the insular cortex. And also we had MTH 3 and 4, which is exactly not the hippocampus. The hippocampus was contacts 1 and 2. This was more about collateral sulcus to the false, to occipitotemporal gyrus. And then the seizures evolved. We captured some of those nocturnal seizures as well, but they were not, the electrographic correlates were not as clear. So there's just a quick summary of the red points are the areas of onset. When you look at the hippocampal ones, the hippocampal electrodes are not the onset, it's just beyond that. Same thing with the amygdalas, the 9 and 10 are the most superficial contacts. Just a quick thing on the lateral radiogram. So these are the contacts where we're seeing the seizure starting. So these are, when you look at it, these are temporal, but not necessarily mesiotemporal, temporal neocortical to basolateral, but still neocortical. And also the middle insula, though it was called the middle insula, these are contacts 5 and 6 of the middle insula. We placed an anterior insular electrode here. To be fair, they're very close to each other. Though I call it middle insula, it's probably more anterior insular. So in this patient who had a history very suggestive of a temporal lobe epilepsy, our conclusion was that this patient had a temporal plus epilepsy. And if I were to, obviously temporal plus epilepsy is very important consideration in some of these patients. It's a big determinant of temporal lobe seizure failure. And looking at the numbers, the insula tends to be the most involved area in these sort of patients. And our feeling was just the nocturnal component, and also the vasomotor signs pointed us to that. So if I were to essentially show what the areas, the areas marked in red are the areas where we caught our seizures. So definitely anterior middle insular, the neocortex, but not the amygdala itself, and then just stopping short of the hippocampus. So going on to the surgical options. So a couple of things on the surgical options, and later these areas to discuss. So we knew this patient, we're going to do a temporal lobectomy in this patient, non-dominant temporal lobe. The question was also, how do we reset that area of the insular? One thing we could do was a temporal lobectomy, and then just work around the Lyman insular to resect as much of the anterior insular as we could. The problem with that approach is that the contacts we had, 5 and 6, were actually higher up in the insular. They were here. And our concern was that we will not be able to reach that high. So that wasn't an option. Another option was we could do a temporal lobectomy and then later come back and do a laser ablation of the anterior half of the insular. Now, we did not go ahead with that. Part of the reason is that, there's been a ton of papers just about when you compare resection versus laser, resection has superior outcomes. But later at the end of this talk, I'll show you another situation where I used it. In this particular patient, we went for a resection. We went for both, temporal lobe resection, amygdala hypercampectomy, but we decided to go for a transfrontal opercular subpial anterior middle insulectomy. Now, the reason I felt I could do that in this case was that this was a non-dominant hemisphere. Broca's was not in the way. And I'll tell you about my approach. And later I'll show you briefly a lesional case, but in which we used a hybrid approach of combining a laser with temporal lobectomy. So essentially, this was our approach. Our plan was to do a temporal lobectomy and go through a transopercular approach. So for this sort of patients, what I usually do with exposure is, with exposure, I look at pars opercularis. Obviously, behind pars opercularis would be motor and sensory, recognized by that, the stem, the brachium joining them. Now, I'll do a temporal lobectomy, but I usually use an approach through the pars opercularis, where being careful about the M3 branches going into the motor cortex, because that's something to be very careful about here. This being a non-dominant lobe, temporal lobe, this is a perfect, non-dominant frontal lobe, and you're not worried about Broca's. There's a perfect trajectory, unlike if you're doing a temporal lobe approach. And so with that sort of approach, I'm able to go subpiral along the frontal operculum, going to the insular cortex, and resect the anterior and middle insular cortex. I do my temporal lobectomy, and all behind the Lyman insula, I'm able to connect both resections together, looking superiorly and inferiorly around the middle cerebral artery itself, and you're able to effect a resection. And that's my preference in this case. This, unfortunately, I don't have the video, but this essentially shows the approach in this case for the anterior insulectomy through pars opercularis, and able to resect that along with the temporal lobectomy and connecting the resections. The coronal essentially shows that temporal lobectomy, but this is the area of resection that connects around the MCA into the area of the temporal lobe. Now, while I've discussed this case, I do think there's a role for a more hybrid approach. This patient was different. In this patient, as is typical with many of our pediatric patients, had a temporal pole cortical dysplasia. That's the most common presentation in pediatrics. They almost always have a live temporal cortical dysplasia. It was dominant. In fact, in this kid, we had to put, this kid was about 9 years old. We had to put a grid, map language, and then come back, do a resection, leaving, parts of the superior temporal gyrus where his language was. And this kid went seizure-free for many years, and then returned with seizures. And in this kid's case, we went ahead to do SEEG that proved that the seizures, the residual seizures, were actually anterior insular. Now, the problem in this case is that you cannot use the same approach we used in the last patient. Trying to do a transopercular approach will not work. And in this patient, we decided to use a lip in which we placed the laser wire, and we were able actually to place 2 laser wires at the procedure. You can actually see the first one, with the enhanced, this is the enhanced MRI scan. You can see the anterior portion has been ablated. The middle portion is being ablated. So getting us a good wedge of ablation and avoiding language in this patient who is left hemisphere dominant. Now, finally, I'm just going to say the pathology file, 35-year-old gentleman came back. It's a type 1B focal cortical dysplasia. This was neocortical. We can prove it because the hippocampus that was removed did not show any appreciable neuronal loss. Some mild gliosis, but nothing to write home about. So this was clearly a case of a neocortical FCD. And the question, just to round up, the question arises, why don't I, in my practice, or Shram, who had the big series, why doesn't he see, why don't we see non-MRI, no MRI abnormalities in kids? And part of the reason we've looked at this is a paper from that, and also neurology. 2 reasons. Number one, in kids, the FCDs are usually larger. Okay, this don't tend to be 1B FCDs. So you get early onset. The other reason is the interaction with cortical functional networks. Kids, so generally, when you look at FCDs and when they start to manifest, so this patient was, the 35-year-old was already born with it. Well, the problem is this: if your FCD interacts with, let's say, somasensory, visual cortex, even default mode networks, it's going to manifest earlier. But if it is limbic, it's going to manifest later. So that's why, even though these patients have a fairly small quantitatively FCDs, it takes time for that to manifest if it's just interacting with the limbic functional networks. And with that, I just want to acknowledge the excellent group of neurologists and neurosurgeons and PAs that I work with. And thanks once again for this invitation.
Oh, thank you so much for this fascinating presentation, Chima. I think we have lots of discussion on this after we hear from Samir Sheth. Samir, would you please join us, share your screen, and present us your case?
Okay. Yes. Thanks very much. Really appreciate the opportunity to present this case. I love this the interactive style of this meeting. So I look forward to doing so once I get through some of the discussion points. I wanted to start by recognizing a couple people. Atul Maheshwari is the epileptologist who's taken care of this patient and really helped gather data and put some of these slides together. And Nisha Giridharan is one of our PGY5 neurosurgery residents, who also helped a lot in getting these slides together. And everyone should keep their eye out for her, because in a couple of years when she's done here, she's going to become a fantastic partner for anybody who wants a very well-trained neurosurgeon scientist. This is the case. So this is a 39-year-old female who started her seizures about 18 years ago. Positive family history, but genetic testing was unrevealing. The seizure semiology was the following. There's a deja vu aura, and then the ictus had staring, perseveration, a bitter taste, altered awareness, and or lingual and bimanual automatisms. A frequency of these FIA events were a couple a week, secondary generalization about once a month. Refractory to medications, and she had a phase 1 monitoring. It's now several years ago, and this is the summary of it in words, and I'll show you some pictures of the EEG. So interictally, there were entirely only left anteromesial temporal spikes. There are 4 events, 2 of which secondarily generalized, all of those with a left anteromesial temporal onset. So I'll prove that to you. So here's seizure 1. This is kind of the background, and here's where it starts just to the right of the screen. You see the delta pattern starting just here. If you can see my cursor, kind of with the phase reversal at TA1. We see that evolve to a theta pattern here very clearly. Again, with the TA1 phase reversal, again, left temporal based on the, the TA1, T7, this looks like mesial temporal with the phase reversal. Here it is, there's more of it. It really stays left temporal for quite some time. The right side starts to come in. And then, of course, as it picks up and starts spreading to the central contacts, et cetera, of course, you see it on the right side as well. But it stayed left mesial temporal for some time, or tens of seconds prior to that. Seizure 2, similar to seizure 1. Here's some chewing artifact in the background. And then you start seeing, again, this theta pop in on the left, again, with the TA1 phase reversal, quite clearly left onset. This is a note here. This is right side, right-hand automatisms. So a little bit of a contradiction, or, kind of a conflict there in terms of the automatisms being on the opposite side of what you'd expect for a left temporal, mesotemporal seizure. So let's keep that in mind. But otherwise, very clearly left temporal on the EEG. And here it is. It gets a little faster, starts to involve the right side, and then generalizes. Okay, so the MRI, I don't have too many shots to show. It's just not worth it, because it really was unremarkable by radiology read, and importantly by our group of neurologists and neurosurgeons. Really nothing remarkable at all. We got a PET scan. A couple representative images here. We thought this was fairly unremarkable. It didn't really show any asymmetry in the hypometabolism. The read, just statistically based on some of the Z-scores, they said right inferior temporal, statistically a significant difference in the uptake. We weren't super impressed by it, but again, kind of back of our mind. Now things get a little bit more interesting. Here's the neuropsychological results. Fairly different than, or kind of opposite of what we would expect for left temporal. Verbal skills were average, 50th percentile. Nonverbal were very impaired, less than 2nd percentile. The interpretation of this was based on a few other aspects that I won't necessarily get into. Bitemporal cortical dysfunction, so not necessarily mesial, and certainly not necessarily dominant or left-sided. So we got a WADA, which we still tend to do fairly regularly for these kinds of situations. The left injection, 7 out of 18. Passing score for us is 9. So this is definitely a failing score on the left injection. A good passing score on the right injection. So our conclusion from this, with this failing score, was that there is memory to lose on the left side, and so this patient would be at risk with the left ATL. MEG, we have the luxury of getting fairly routinely when we want it. So here's a number of dipoles on the left. You can see them certainly mesial temporal, so plenty of mesial temporal dipoles. Maybe a little bit of superior temporal sulcus, certainly some in the insula on the left, and then here are right-sided dipoles. Again, plenty of right mesial temporal, a little bit higher up, mostly mesial temporal on the right side. So as a summary, here's kind of the data in summary. If we say the hypothesis is left mesial temporal, there's certainly some concordant findings. The semiology, the interictal, again, really not a single right-sided spike, all left interictal. The seizures I showed you very clearly left mesial temporal. MRI, let's call it non-diagnostic. The MEG, I put parentheses around discordant. It's concordant in that there's left mesial temporal and left insular spikes, but there's plenty on the right as well. The PET, you could say was non-diagnostic, but if you take that read a little bit into account, then perhaps it's a bit discordant, because maybe there's right-sided hypometabolism. Again, not impressive to us. The neuropsychological testing in WADA, we're certainly not concordant in terms of having fairly preserved verbal function and pretty profound nonverbal dysfunction. So we decided to do a phase 2 stereo EEG to test this hypothesis of, is this truly just left, or could it be bilateral and mesial versus cortical? This is just a couple, representative pictures of our implant plans. We did several left temporal, some left insula top down, along the axis of the insula, and then of course some on the right side to disambiguate right versus left. With the phase 2, here's some representative screenshots. Here's an interictal from the left hippocampus. I'm not showing the right side here, but this is a left-sided spike. Now here's a right-sided spike. Here's a right hippocampus spike. Again, remember, we didn't see any of these on the phase 1, the scalp EEG. There's no right interictals. So here's some. We got 2 seizures on this phase 2, and just showing the context here. You see this a heralding spike here, some fast activity start, and this is really left hippocampal, head, body, tail. Very clear takeoff here in the left mesial temporal structures, and at least 8-10 seconds before we start seeing anything on the right side. And then here's seizure 2. Similarly, I'm not showing the right side context here, but take my word for it. Again, is some fast activity starting here, and then the seizure really starts in the left hippocampal, head, body, tail. And it's again, 10 to 15 seconds later before it starts on the right. Okay, so what do we have so far? We have, I mentioned the summary of the phase 1 data. If we now add the phase 2 data, further evidence of the left hippocampus clearly being involved, but we do have some right hippocampal spikes. And, we didn't record a right hippocampal seizure, but, we only recorded 2 seizures on the phase 2. And we'll keep that in mind as we come back to how many seizures do you need to record from one hemisphere, one temporal lobe, to prove that the other one is not involved? We'll come back to that. So what's our plan? I'll say what we did, and then again, we'll discuss afterwards. So this is where I'll start talking about responsive neurostimulation, and I'll spend a bit of time on this. It's FDA approved here in the US, but not really available outside. So I'll talk a bit about it. We thought, because based on the WADA findings and others, we thought that the left temporal lobe would not be safely resectable. We discussed this with her. Obviously, she was not excited about a memory deficit, which we predicted that she likely would have. So the RNS implant that we decided to put in was going to be bitemporal, bihippocampal. We put one lead in the left hippocampus, and again, I'll show you this in a second, in the left hippocampus because it's unresectable. We can't take it out without memory risk, and we do think at this time that this was the primary seizure onset zone. We put the other lead. You can put 2 leads in this device in the right hippocampus. There's some data pointing to that in the phase 1. I mentioned the neuropsych results, and the PET plus minus, the MEG had some right hippocampal, right mesotemporal component to it. In the phase 2, we had some spikes on the right side. So we did a bihippocampal implant, which is the most common type with RNS. So a bit on RNS as a bit of a sidebar here. This is a device. It's the only closed loop cranial neuromodulatory device that has any kind of approval. Again, it's approved here in the United States. It does, it functions sort of like a cardiac AICD. So, it's not a pacemaker type of thing where it's on all the time. It's monitoring all the time, and then it fires only when it identifies a pattern of activity it's been trained to detect as a potential lead into a seizure. So it's monitoring constantly. It's taught to recognize and then respond to a particular pattern of activity. The epileptologist teaches it how to do this, and then it delivers therapy when it recognizes and responds to that pattern of incipient seizure activity, and then it goes back to its recording capability or background function. This is what it looks like. It's about 8 by 2.5 centimeters or so. Accepts 2 electrodes, which can be either a depth lead or a strip lead, and I'll show you some examples of that. A lot of different configurations you can use this. This implant, the IPG, unlike with deep brain stimulation, which is typically a body chest type of implant, this is always a cranial implant, and I'll show you about that. So it's implanted within the skull. A lot of different configurations. This is, like I said, the most common one, bihippocampal, with 2 leads, typical from an occipital long axis approach into the hippocampus. But there's any other configuration you could possibly imagine. Here's a couple in a cortical area. Here's hippocampal one, and then an insular one. For perhaps like Chima's previous example, for a dominant temporal insular type of epilepsy, this could be a possible configuration. Here's one with a hippocampal lead, and then a strip underneath that underneath that temporal lobe. Just some considerations about the IPG itself. It sits within this ferrule or tray, which, as you can see here from these screw tabs, is screwed into the skull. It has a curvature to it, of course, because it's sitting within the convexity of the skull. And so, typically where deciding where to put this, there's a number of considerations, but one is that the curvature of this thing, which obviously can't change, should match kind of the curvature of that individual skull where you decide to put it. So that's just something to plan kind of, non-sterilely as you're setting up the surgery. It has sort of a chirality to it, meaning that the leads exit from, if you're looking at the top down, if the curve is down here, the leads exit off to the right. It's important to think about that in terms of how you're going to manage where the wires are going subgaleally. So the first step of this kind of procedure, is stereotactic planning. Use whatever you're comfortable with, obviously. Here's a ROSA robotic way of doing the plan. Again, an occipital long axis approach. I try to put the tip just beyond the head of the hippocampus into the amygdala. You have about 32 millimeters of span on the wider spaced leads, which I'll show you in a second. So you can get maybe the tip of the deepest contact in the posterior amygdala, and then at least 2 contacts well within the head and body of the hippocampus, and possibly a third depending upon your angle and whether you have 30 or more millimeters of hippocampal range. This series of pictures now, these are actually with Guy when we were both at Columbia, when I was at Columbia. So you can do this with a frame. So here's just a stereotactic CRW frame and arc system. And so you can see the patients facing the other way, obviously in a slouch seated position. We would make 2 incisions occipitally here for the leads, and then a sort of a candy cane hockey stick shaped incision for the IPG in this parietal region. Again, this can, the ferrule of the IPG can be placed wherever. We tend to put it kind of on the top of the head so that later on, during life, they're not always sleeping on it when they're lying down if it's back here. If it's here in the temporal area, that's another place some people put it, but then you got to go through temporalis, which is, uncomfortable, and the bone thickness, varies obviously in the temporal squama. So this high parietal area, whether left or right, tends to be a pretty nice place to put it. So here's one, just a prep position where you can kind of accomplish everything all at once. So here it is with the frame, get the coordinates obviously in the typical stereotactic way, 1 inch or so incisions. You can make a burr hole using a perforator or with a high-speed drill. I tend to secure it just with a dog bone with a shock absorber to prevent damage to the lead. The kit also comes with a burr hole cover, DBS style, if you like. There's a template that comes in the system where you can, again, match the curvature to the patient's head, and you can just use that to plan your incision. So here's that part of it. Make an incision. It's a craniectomy. Originally, kind of 10 years ago, people would kind of thin the bone and not do a full craniectomy, but the bone grows back over time, and it's just kind of too much of a hassle. So typically, most people now just do a full craniectomy and discard the bone. You see here the ferrule. Again, you can use this template to draw out with a marking pen, or maybe better, a bovie, the shape and size of this template, and then use your perforator and craniotome to make a appropriately sized craniectomy. Then you just route the wires, just run them subgaleally, and just keep in mind, again, the chirality of this thing. So with the round part facing down, the leads are going to come off to the right as we're seeing it. So they're going to come in this direction. So, route the wires subgaleally so that, they're easy to access here. And importantly, later on, just think about a battery change. When you need to change the battery for this, you don't have to open this whole incision necessarily. You only need access to the back part of this. So ideally, route the wires so they're not running under the incision that you're going to make years from now, so you don't have to worry about it. So in this case, route them like this so that when you open up later on here to have access to the back of the IPG, you're not going to come down on a nest of wires. Again, I'll show you more pictures of that later. Then you can partially close. You can bring in the programming wand and sleeve in a sterile sleeve. Check the electrocorticography, impedance, et cetera. Make sure the device is working properly before you fully close. I should say, at this point, the therapy, once the surgery is done, the therapy continues at home. The patient is issued a programming wand like this and a laptop, and they download their ECOG seizure data to the laptop, which then sends it over the internet to the epileptologist, who can review the data. Next time the patient comes in, the epileptologist can make changes to the detection settings so that the device is trained on how to recognize that individual patient's seizures, so that it does a better job of stimulating and stopping them. So that's with a frame. This is a paper we wrote with a former trainee, Patrick Harris, who's now faculty in Galveston here in Texas. Using a robot. In this case, it's the Rosa robot. We use the Lexel G frame as a head holder and as a registration mechanism. You can see here, it looks kind of funny because it's backwards. This is for, again, a bihippocampal, bioccipital trajectory where the patient is prone during the procedure. I'll show you a picture of that. So we kind of set the frame up backwards with the long posts on the side of the straight part of the frame and the short posts on the side of where the nose piece typically is. And you can see here that this long post is taller than the other one. We put them in a non-coplanar configuration, so the 4 points are not in a plane, so that it facilitates registration. So here's what that looks like. Here's a patient in the frame, they're prone. There's a nice sturdy head holder that holds this frame in place. You can see again, the bar part, the straight bar part is in front of the nose, and this curved piece is in the back. We use the divot within these 4 pins for the frame as fiducial markers, since they're rigidly affixed to the skull. And so we can pick these out, on the software and then navigate the probe, and do the registration off of those frame pins. Here's the equipment that we use for this. We use this slotted cannula, which I'll show you again in a second. Here's one of the depth leads. You can see here that's a wide space, 10 millimeter space lead. And I'll show you a picture of that in a second too. Like I said, we use kind of just a dog bone with a little piece of plastic shock absorber to fix this thing. So a small burr hole, smaller than a perforator size, just enough to be able to open the dura and see that you're not right over a vessel, et cetera. And then just, we fold the lead out over the dog bone, over the burr hole. You can kind of bevel this a little bit to make that a gentler turn, and then use this little piece of plastic shock absorber to prevent the dog bone from damaging the lead. And then tunnel them, again, make your craniectomy, put your ferrule or tray in here, secure it down, and then here's what it looks like finally. Again, the wires are run like this, and they're all subgaleal here, so that later on, when I come back to open up this incision for a battery change, I don't, encounter wires right underneath here. And this is done, as you can see here, with intraoperative fluoroscopic CT, so that, we can, before we leave the OR, we know that the leads are in a good position. So these are some electrodes that are possible. I won't talk too much about the strips for this application, but there's 2 depth electrode options, one with narrow spaced contacts that are 3.5 millimeters apart. And the one that I typically use for the hippocampal or bihippocampal are the ones where there's 10 millimeter separation. So from tip, front tip to back tip is about 32 millimeters. So again, that's when you're planning the stereotactic trajectory, it's nice to, use that full 32 millimeters, maybe have the front contact just, nestled into the back of the amygdala. And you have these 2 in the head and body, and hopefully this maybe just in the tail if the trajectory is just right. One more thing on this, the tail length, the overall length of this electrode comes in 2 sizes, 30 and 44 centimeters. I tend to use the 30 because otherwise there's a lot of excess wire just floating around subgaleally, which is annoying. But there's a important point to that, which I'll talk about here. So the 30 centimeter lead is good in terms of leaving the least excess wire floating around subgaleally that you have to tuck under and get out of the way. But it means that with typical cannulas, that you put these leads into, you're not going to be able to access the lead on both sides of the cannula because this thing is too short. And so here's this slotted cannula made by AdTech. It's got this slot down its entire length. This is what I use as opposed to typical full cylindrical cannulas, because again, if you put this cannula and you put the lead in, the lead is too short to be able to access it above and below the cannula to take the cannula out. So with this slot, you can basically put the cannula in, take out the stylet, put the lead in, and then just bend the lead out through the slot, take the cannula out. So, because you don't have the distal control. Okay, craniectomy considerations. There's a little tab here where the set screw sits in order to secure the IPG in place. It's nice to make your perforator hole here so that this thing sticks out and you can easily let this sit in. I would suggest oversizing your craniectomy just a little bit so that you're not just struggling with the fit of this tray in the skull. The leads go into this little connector box that screws into the top of the IPG. This is a little clumsy, futzy. It's there's no way to really secure these leads in here other than just holding them in place. You need to make sure that you put them all the way in, and you can check that with the live electrocorticography. This is a picture of something that I may not recommend doing, with wires running, all around the back of this thing, where you're going to come back for a later battery change. The batteries used to last only 10 years. So imagine coming back every 2 years through a scalp incision. Number one, that's not great. Number two, if there's wires underneath here, you're going to be hating yourself. The battery now lasts 8 years in terms of the clearance or the approval. It's real life is actually more like probably 10 years. So it's actually not bad at all. It's not uncommon to put in extra leads. The device only allows for 2, but some people put in more than 2. If so, you can put the other ones, here alongside it, and you can come back and just through a scalp incision, attach other leads that you've already put in stereotactically or otherwise, so you don't have to do a big cranial surgery. Just a few words on data, just in case, again, there's folks outside the US that, haven't had personal experience with this. This is the pivotal trial published now 12 years ago with 240 patients. The design was after implantation, there's this 3-month blinded evaluation period of treatment versus sham in a double-blinded fashion. Here's the results. Here's the sham patients. There's an implant effect where the seizure count does go down, and then it sort of levels off in the sham patients. Sorry, this is the sham patients where there's the implant effect. And then, it returns back to baseline during sham stimulation. And the active patients, of course, continue to improve with the seizure reduction. And these data were, significant enough to get approval now about 10 years ago. Long-term follow-up in these patients, this is not a therapy like Chima mentioned. This is not a therapy that we think of as one for seizure freedom very often. Seizure freedom rates are in the single digits, the mid single digits. This is a therapy that results in seizure reduction in a case where you can't do a resection or ablation. And so 6 years later, here we are around 50-60% seizure reduction. This is an interesting point that I want to mention briefly. This is a nice paper that came out now 8 years ago. This device, besides stimulating, obviously, is recording all the time. And so it's really like a long-term, it is a long-term chronic ECOG monitor. And these are some nice data just showing like how long does it take for the seizure to appear on the side opposite from where you've gathered them before. So meaning if you have an implant in both hippocampi, how long does it take to record your first seizure from the opposite side, the side that is seizing less often? So about a third of patients, it takes about a week to see that. But as you can see here, in a third of patients, it takes more than 4 weeks to confirm that there are seizures coming from the other side, the contralateral side. You can see here the long tail here, where some of these are many months out before you record that first seizure on the other side. And that's important, obviously, for prognostication. Here's kind of a quantification of this. In 11 patients with presumed unilateral onset, 7 of these, more than 2/3 of them, had actually bilateral seizures. So you should make a decision with these patients, that it's going to be unilateral because 2/3 of them actually had seizures also coming from the other side. And of the 71 patients that were thought to be bilateral, 13% of those actually had only unilateral seizures. So these become candidates for resection or ablation, which of course is going to have a better outcome than neuromodulation. So that chronic monitor function can be very useful. Finally, just the modern experience. This is now just a few years old. We're up to somewhere in the 70 to 80%, maybe just above 80% seizure reduction regime. Okay, so back to our patient. So we did, so as I mentioned, because of the unresectability of the left side and, some hints pointing to seizures, or activity on the right side, we did this bihippocampal implant. 2 years later, we're, a couple dozen seizures in. So first of all, she's doing, reasonably well, 75% seizure reduction. But surprisingly, almost shockingly, almost all the seizures, all but 2 of the seizures came from the right side, okay, which is the side opposite where we had all the data, right? Phase 1, interictals only on the left, seizures only on the left. Phase 2, some interictals on the right, but seizures only on the left. But surprisingly, over the course of 20 seizures or so, on meds in her real world situation, she's mostly seizing from the right side and not the left. Here's an example of this. This is what the recordings look like, in the software. We can look at this. So these are the 2 hippocampal, the 2 left-sided bipolar montage on the top, and the 2 right-sided on the bottom. You see here, here's the detection on the right side, right hippocampus, and then the therapy is delivered. Here's another seizure, same thing. The left is, pretty quiet. Here's the detection on the right side, and here this is super busy. But the point is, the top 2 lines here, are quiet, and the bottom 2 lines, that the right side is where you have the seizure. So left over right, right side seizure, right, et cetera. So over all of these detections, these are all right-sided seizures, despite all the phase 1 and phase 2 evidence. So again, the phase 1, and phase 2 were all left temporal. Rights, the RNS showed the vast majority of right temporal. So now, a couple of years into the therapy, she's doing reasonably well, but she's still having seizures. So now, she'd be actually a pretty good candidate for a right ATL, which based on all the, the data I showed you before, ought to be reasonably safe. So to summarize, this is a closed loop responsive neuromodulation system approved for 1 or 2 seizure foci. It's a very reasonable consideration for dominant MTLE, which we thought this patient had, but it's also has this long-term monitor function, which is an added bonus, which in this case for this patient, may allow her to have an even better surgery on the other side. So with that, I'll say thanks, and hopefully there's some time for discussion.
Yes, we do have time for discussion. That's the main issue for this webinars. While we wait for input from the audience, maybe the panel could join us and start the discussion. Guy, Jorge?
Maybe I can start.
Yes, please, Christian.
So I have a question for Chima. What was the outcome of your patient?
Yeah, so this patient surgery happened about 6 months ago. The patient has been seizure-free. Used to have nocturnal every night, the shorter type seizures every night, has not had it. Has not had any seizures since then. We'll still wait to see, but hopefully the patient continues to do well.
Hi, Chima, it's Guy. I'm sorry, Christian, you still go ahead.
Oh, yeah. A second question. If I remember correctly, you had electrodes in the pars orbicularis and triangularis of on the right side, right?
Correct, yes.
They were negative, right?
They were negative, correct.
It was the argument for you not to go for a resection. Okay.
Exactly.
Hi, Chima, it's Guy. That was a beautiful case. I was wondering if you could talk a little bit more about, and I want to make sure I caught all the data right. It looked like your onsets were kind of, you had a broad zone between anterior insula and temporal pole. And my question is, particularly in such a high functioning patient, did you consider a more tailored temporal resection where you didn't have to do a full temporal lobectomy? Do you think you would have been successful just with an anterior insula and temporal pole resection without doing as extensive of a resection? Again, particularly even though non-dominant in such a high functioning individual.
That's a great point, Guy. What we found, especially now, some of this I'm being retrospective, especially what we know with the type 1B focal cortical dysplasias are, these tend to be fairly, just the cortical malformations tend to be more widespread than, we see. And generally with those, when we go for now, some of what we do in pediatrics influences what I applied in this case. For some of those patients who tend to have, we think that they may have a more widespread epileptic focus, especially because we're thinking it's a cortical dysplasia. We tend to do a big volumetric resection. I do agree that there could be some implications for a high functioning person like this. But generally, our feeling is that you're going to get better seizure freedom rates with bigger volumetric resections. Okay, I'm sure there's a downside to it in terms of cognitive outcomes, but we felt we'll get better results in this patient.
And then, Samir, that was also a really fascinating case. Just a question, you've talked about sometimes adding additional electrodes to come back and potentially use. And in a case like the one you showed, where there may be a possibility of one-sided resection in the future, are you now up front adding like a subtemporal strip on each side in addition to your depth, so that if you do a resection, then you've got 2 electrodes for the other side? Or do you wait and then add that on in the future if you need to?
Yeah, it's a great question. Years ago, people started talking about kind of the addition of an extra electrode so that it's just easier to connect it. For the most part, we only do that when we have really pretty compelling data, and we really can't. Let's say there's three potential areas that we want to target, and we have a top two, but the third one is a close third. We would do it in that case. Certainly not routinely in the case of a bitemporal implant. We're certainly not routinely putting in the two depths and the two strips, not at all. In fact, I think we are we've talked about this recently, kind of trying to be more thoughtful and systematic about what is the data threshold to where we're going to actually come back and change the change the electrodes, right? I mean, we put them in so that we have them there. But at what point do we say, all right, we're not doing well enough and we're going to go back in and just, connect the other electrodes? Like, what is that decision threshold? Because we haven't done it much. I've put them in many times, and I can think of maybe once or twice when I actually gone back and tried additional ones. Because, you just kind of keep trying, and you could do that for years, you could do that forever. So we're trying to be thoughtful about when we do it, because we don't go back and make that change very often.
Yeah, I completely agree. As oftentimes the neurologist will be like, "Oh, we'll just put these other electrodes in case we want them in the future." And I personally, I know there's a lot of centers who do it frequently. I personally try to resist that instinct.
Yeah, I think so. It's a slippery slope where you're like, okay, you've done this now, and there's a tiny risk to everything. And then when do you actually come back and use it? We have not found ourselves using it much. I think if there's places that actually thoughtfully do this and say, all right, we're going to wait X number of months, and if the proven is not beyond this number, we're going to come back. Fine.
Jorge?
Chima, my question was to you, and I also have a question to Samir. First of all, congratulations for both presentations. I wonder, Chima, I have two questions for you. First of all, is that did the neurology team try to narrow down the extent of the epileptogenic zone by performing electrical stimulation? You consider this to be temporal and anterior insula, but if there was any attempt to see if the anterior insula was the early spread of the seizures, and maybe not necessarily to resect. And the second question that I have is that once you went to the insula, what was your criteria to define the posterior margin of the resection of the anterior insula? What do you use as your surgical criteria?
Great, thanks. So no, we did not stimulate this patient. I must say that stimulating through depth electrode is something that we are beginning to introduce more and more into our practice. One of our colleagues, adult neurologist at GW, has pushed for stimulation of all cases. You have SEEG, you still stimulate. Unfortunately, we did not do that in this case. With regards to the question about our posterior extent. So the 3D surgical theater picture I showed, I use it for navigation, essentially. And so I resected essentially the anterior half of the insula behind the most posterior electrode, behind that middle electrode. Now, I had a posterior insular depth electrode, which we didn't see activity. So I was, at least I was reasonably confident that, I did not need to go as far as the posterior insular. So that's what guided the resections.
Berto?
I would like to have a technical question to Samir, and that is regarding the RNS. So if I get it right, you have two hippocampal electrodes, and then if you find a seizure in one of them, then the device delivers a stimulation in that electrode. Is that correct?
That's correct.
And this extra subdural that we see on these overviews you have, what is that for?
Sorry, extra subdural.
In one of these sort of overviews, you have two hippocampal electrodes.
Right.
And then you had a 4-polar subdural also.
Right. So that I think I stole that picture from somewhere. That was definitely not the case. In this case, we just, had just the two. This is what we're just mentioning earlier, where, some people will put in additional electrodes. So in that picture, for example, the extra two would be unconnected. They'd just be sitting capped next to the IPG for future use if needed, if necessary. So the idea being that, okay, if you put in more than two, well, you can only connect two, so connect your favorite two. But then the other one can be sitting there so that later on, if you decide that your first two are not great, you can just go in through a very small surgery, unplug one or both of them and plug in one or more, of the other ones that you've already put in, and they're just sitting there waiting, ready for you.
So that is mostly if you are not completely sure, and then you get rid of this problem with going in a second time.
That's right. It avoids a burr hole craniotomy,
Yeah.
stereotactic procedure,
Yeah.
et cetera. It's just a simple skin surgery. That's
Okay.
right.
Okay.
But like we said earlier, do it thoughtfully, because, what is your threshold for actually going back and reconnecting?
I recognize this discussion of just putting extra SCG electrodes from my hospital, and I must say, so far we have always refused.
Yeah, I have some issues here from the audience. One of them, I think, was already answered by Jorge's question. That was if you would consider doing only the temporal resection and not including the insula. The other question is related to would you change your mind if you have a normal MRI in a temporal lobe epilepsy patient, if this patient has a positive PET? How does this change your mindset and your workup? The question could be rephrased like, what is the actual importance of PET in these patients with normal MRIs?
Yes. So, my view in this particular case is that it would not have changed my mind in terms of going for invasive intracranial monitoring. A PET scan just does not have sufficient localization value, to make that decision. That could be helpful, lateralization value, but just not enough. Now, I recognize maybe 20 years ago, with the evidence we had on this patient, some people would have done the temporal lobectomy. It's possible. But with this particular patient, there was also the question of the semiology. There are some questions about this patient's semiology that suggested that there could be insular involvement. It was pointing to temporal, and the PET scan was not sufficient to do that. Now, with regards to whether we could have left the insular and just gone for a temporal lobectomy, the suggestion, and I showed that paper by our colleagues in France on just this being a determinant of long-term seizure, post-seizure outcomes. Leaving, so in that situation, a temporal plus epilepsy, I do think, and I've seen it, like the one I showed you with the laser, where these patients do well for a long time, then they return with seizures, and you still have to tackle that insular focus as well.
I put in the chat, I mean, if I remember right, there's a paper from the Jefferson group, Mike Sperling and Ash Sharon and Chen Wu, I think some years ago, talking about MRI normal patients, but with a clear, hypometabolism on one side. I believe they did show some lateralizing value on that. That being said, I can't think of a single case where, we made a decision to do a resection, for example, just based on PET hypometabolism, with everything else being, MRI normal, et cetera. I think even PET plus MEG we'd still probably do, an intracranial evaluation before doing resection or ablation if everything else was, non-diagnostic.
Well, but then if so, and being the EVO advocate, why would we need PET if we don't change our procedures?
Yeah, that's a good point. sometimes I think our approach to many of these things is just an investigative approach, right? We want to add layers and layers of evidence. And I think traditionally people have always done that. I think maybe things have, I think just at least with the views of SEEG and the way people can do invasive intracranial monitoring, you're not using grids. I think people have moved more towards wanting to do invasive monitoring. But that's a good point. What's the role of PET? I still think it helps. In our own case, for example, it helped us say, you know what, we're going to do intracranial monitoring only on the right side. There's just enough evidence to focus on the right side. So it can help direct that, but I'm not sure it is the game changer, makes you make a decision to go to resection.
Guy and Berto, are you touching on the PET issue, or is the different thing?
I can comment on the PET.
Yeah,
But you go first, the guy.
no, go ahead, because my question is separate.
Okay, there is a Norwegian paper from Hugo Ivanovic, who I also see is in the audience, that really uses PET specially for non-dominant temporal lobe resection with the normal MRI, and they have quite good results in that. And if you want to comment, Hugo, you can do that in the question and answers or chat or something.
But then this discussion can goes to other available tools in the preoperative evaluation. Let's talk about MEG. Samir, Chima, any input ideas on the value of MEG in temporal lobe patients with normal MRI?
We use it quite a bit, to be honest, unless the patient's insurance doesn't allow us to get one. We get one fairly routinely on non-lesional, non-MRI lesional cases. I think philosophically, maybe similar to the PET, in that if that is the only lateralizing data, we're unlikely to make a resective or ablative decision based on it. But we use it, as an adjunct to everything else to decide how narrowly or widely to create a hypothesis. Temporal, temporal limbic, temporal plus, unilateral, bilateral. For example, if everything is pointing on one side, but there are abundant dipoles on the contralateral side, we're not going to ignore that if we're going to do an invasive investigation. Similar to, PET, if everything's pointing to one side, but there's very clear hypometabolism on the other side, it's hard to ignore. You could add to this, what about neuropsych testing? Is that enough to make you, make a unilateral implant into a bilateral one, if that's the only discordant thing? I think all three of these are sort of in gradations of, to me at least, not going to make an irreversible decision based on just one of those, but perhaps any one of those would influence, where we would look in an intracranial.
Yeah, just to add to that, yeah, we do MAG, especially if there's enough interictal spikes and so on. But once again, just like Samira, I cannot remember a decision where we went ahead straight with a resection based on MAG. I find the MAGs, especially some of those kids who have, you're wondering if they have a wide network. I actually use it to direct where my SEEG wires are, trying to put the SEEG wires, where clusters are, just to get better diagnostic yield. But still, I'll go ahead. And in this situation, with the history, the semiology as I know, that's still done. Even if neck pointed, just say it was neocortical, that's still going ahead with that.
Before you go ahead, Guy, I think there is an interesting question from the audience. Would there be any circumstance where you would think that a patient with temporal lobe epilepsy and normal MRI could go straight to surgery, skipping an invasive evaluation?
Yeah, so tough question. As in most things, I'm sure there could be a situation, but I have to look at our practice, right? let's say, someone's semiology is clear, and everything points mesiotemporal. We probably might, but just from our practice, I suspect we'll probably do invasive monitoring. For an MRI negative, all we have is lateralization. We probably will investigate. And once again, I must say, in the pediatric population, which is what I do most of, the proportion of isolated MRI negative temporal lobe seizures is very small. So that caveat. But we will probably investigate, because a lot of our patients will tend to have multi-lobar type seizures. They will tend to have type 1B cortical dysplasias that is usually not restricted to just the temporal lobe, even if we can't see it.
Yeah, I say, the similar, really. I cannot think of a case where we've done that. I think what would have to happen, I'm not sure this has happened yet, it'd have to be where the scalp EEG was not just 2 or 3 seizures captured, but many, many seizures captured, with the other side being really bland, no interdictal, et cetera. MEG, PET, everything, pointing to that side. Maybe, but I don't know if that's happened. So I would say that we probably haven't done that, and probably unlikely to do that.
Okay, great. Guy, would you go ahead?
Yeah, so actually, I have a follow-on question as part of that just came up, but then also a separate one. So the follow-up question is, Chima, you talked before and you showed that pediatric case where you put in a grid. I think in the days prior to when there was a lot more SEEG in the US, when the choice was a grid versus a non-dominant temporal resection, a lot of people were more aggressive with temporal resections without an implant. But now with SEEG being so much less invasive, I think a lot more people would do an SEEG first, where they wouldn't necessarily put in a grid, particularly non-dominant. That's just a comment. But my question, Samir, your case was fascinating because, as you said, there were many things on the right side up front that made you a little bit worried, in terms of the interictal EEG and the psych testing and the WADA. But what about if you have a pure dominant temporal situation where you didn't have that, and you're going to do a dominant temporal RNS because of your concerns? So my question is, what are you doing with the second electrode? Because initially people would always put it subtemporal and try to get a mesial temporal stimulus, and the thought being you can have a hippocampal depth and a subtemporal and you get a greater stimulation field. Seems like a lot of people now are starting to play with the thalamus with the second electrode. And can you comment on that, whether you think there's enough data to put the second electrode in the anterior nucleus as part of a limbic circuit? As you know, there's a lot of interest in people. It's almost a merging of RNS and DBS, where they're becoming closer and closer to each other, yet you have the ability to record with RNS. And what are your thoughts on the thalamus as a target for a second RNS electrode?
Yeah, that's a great question. So I think it depends on one thing, is whether they've had an intracranial, like if they've had SEEG or not. If they've had SEEG, hopefully it was bitemporal. And if the other side is totally clear, then okay, we wouldn't put that in. If the SEEG included a thalamic nucleus and there was activity there, then we consider that. So, if they've had an SEEG, then I think, where to put the second electrode would be either thalamus or the other hippocampus, or somewhere else based on the SEEG results. If they haven't, which, is not uncommon, if they haven't, then I would say, without any intracranial EEG, our default would be bihippocampal, because I think it's pretty easy to be fooled, in terms of the lateralization, and you start getting some seizures on the right side, and you never know that otherwise. So the only way that I think that we would put in, left hippocampus, so the most likely thing would be bihippocampal. The next most likely thing would be left hippocampus and subtemporal strip on the left side. Again, I answered one answer in the or question in the chat. There's some emerging very case report level evidence that maybe a depth and a strip is better than a depth alone on one side. I think very much to be investigated. So that'd probably be the next most likely thing. I can't think of a case where we've done hippocampus and thalamus just based on phase 1 data. People are definitely doing that. I think it's pretty interesting. Yeah, like so left ANT and left hippocampus, and you're getting kind of 2 spots in the circuit. So I think that's an interesting idea that we don't do very often. So that'd be the least likely thing that we would do, I guess.
And just to add, I just wanted to add, the absolutely, Guy is correct. We rarely do grids now, but pretty much the only indication I do grids is the indication I did in that kit. So most of our patients who have lesional epilepsy tend to have temporal pole epilepsy that's pretty extensive. In fact, this patient's the patient was a dominant left hemisphere. The obvious radiologic abnormality extended beyond 3.5 centimeters, and we're worried that the dysplasia was, encroaching into motor cortex. And usually at that age, what we find easier is just to put a grid and do extraoperative mapping. So that's almost the small group of patients I do grids now. Pretty much all grids I do is for extraoperative mapping in these kids who, we couldn't do an awake training. So that was the situation in that case.
Perfect. Jorge, please. You're quite quiet today.
Yeah. So my question goes to Samir about the management of the patient and the SEG exploration. And Samir, I was interested about the history of this patient and the scalp EEG. And when you present, and of course we have limit time here to present, I agree that the hypothesis was mesial temporal. But I am not sure if this was a hippocampal seizure. This patient with this olfactory and also the prominent oral automatism, it points perhaps a little bit towards the more anterior compartment, more rostral on the mesial compartment. Maybe the amygdala was involved, the cortex around the perirhinal. And if we had located the epileptogenic zone in that location, even if it's dominant side, perhaps we could propose a resection for this patient rather than a palliative procedure as an RNS. So I wonder if you were satisfied with the SEG planning for this patient, because you pretty much map very nicely the hippocampus, but I didn't see any considerations about mapping the entorhinal, the temporal pole, and also the amygdala. Perhaps this patient could have been a surgical resective candidate if we had perhaps localized the epileptogenic zone outside the dominant hippocampus. I just want to know your thoughts about that.
Yeah, that's a great question. I guess 2 things I'll say. One, in this patient, we didn't have, you're right, we didn't have amygdala. We could have, maybe we should have. We had, oftentimes when I put in, the mesotemporal ones posterior to the amygdala, I kind of, have 1 or 2 ending in hippocampus and 1 or 2 ending a little bit lower in entorhinal. I don't remember if we did that for this. So I can't say that we ruled out, entorhinal and separated from hippocampus. But what was very clear was that it was not left-sided long-term, right? So I don't know if the question was included that, but certainly if we had made, I guess we couldn't have made a decision to do a dominant resection in this case, because on the phase 2, we did have, erectals coming from the right, and we had some other soft data coming from the right side. And as demonstrated, with the RNS, the vast majority of her habitual seizures at home are right-sided. So obviously, good thing we didn't do a dominant temporal resection ablation, et cetera.
Okay.
Yeah.
Go ahead, Jorge.
No, I think it's something. Yes, I understand your argumentation, but the fact that you're recording from the RNS seizures from the right side, and you have very limited sampling on the right side and also on the left side, on the left side, it does not mean that it's coming from the right. So it's a little bit. I think it's when you have very few contacts just purely on the hippocampus, it's truly very difficult to define if the seizures that you're recording from the RNS only from the hippocampus on the right side are truly being originated. There is definitely a spread, especially if you don't have additional coverage on the left side. So it's a very, I think it's very complex it's a complex network. And I think if you don't have the appropriate sampling of both networks, it's very difficult to make this argumentation. Probably this patient had left side epilepsy, an epileptogenic zone located on the left side, and we see spreads toward the right side as well. If we had perhaps a little bit better coverage of the anterior perceiving areas, we'll probably define better the epileptogenic zone. But again, very difficult to really understand this in such a short amount of time. But very interesting. I think I would have those considerations about this case. Yeah.
Okay. Yeah, that's interesting. So you're saying left amygdala, left somewhere else where they're still all starting there, and even though we're capturing them on the right side in the hippocampus, long before many seconds before clinical onset, et cetera, and many seconds before. So you're saying left amygdala or elsewhere, that then goes to right mesiotemporal and then to left hippocampus.
Yeah, the pattern can be very different. It can have preferential patterns of recordings. And this is particularly true when you have mesiotemporal pole epileptogenic zones. They tend to spread in a different pattern. So
that's interesting. Yeah, I don't think we considered that. That's a great point. Maybe we should think about that before we offer her a right ATL.
So we are approaching the end, but I have two quick questions that I kind of summarized from the audience. Chima, this patient has no visual memory deficits before surgery. Is that correct? Your patient?
Yeah. His neuropsych scores. Sorry, I didn't show them, but they were actually above average.
Yeah. So the question is, you resected the right hippocampus, and it's very likely that you're going to generate a visual memory deficit. The question is, what is the impact on a person's life with newly created visual memory impairment? Is it significant?
I mean, no doubt that's a very relevant question. This patient he's an IT specialist. A lot of what he does is more someone who depends on his verbal memory. The plan typically what we do is a year later we repeat our neuropsych test. It will be interesting to see what impact that has on his visual memory, but he's back to work. He reports he's doing well at work. I think he feels he's doing better because he's been able to go off some of the medications he is on. But I would not be surprised if neuropsych test showed, an impact on his visual memory. But we've not seen that impact evident in his day-to-day life and function.
Thank you. And Samir, basically what people understood is that you had a patient with neurophysiological phase 1 data exclusively on the left. And then you decided to do a bilateral implant. In what basis did you choose to do a bilateral? What drove you to the right?
Right. Two things. One is we captured 2 seizures on the left. Okay, so that's exclusively left, but it's not 20 seizures on the left, it's 2. And then there were a number of things pointing to the right. I mean, even semiology, it was right hand automatisms. The PET was plus minus, the MEG was pretty clear, spikes on the right, right mesiotemporal. And then the neuropsych, showed pretty preserved verbal function and barely impacted nonverbal function. So there were several things, any one of which, by itself wouldn't be enough for us to do a resection on the right, but all in combination were definitely enough to be worried about the right.
Which means that you have a positive MAG to the right and negative neurosurface scalp EEG. You never had a spike on the right at EEG, and you have a positive MAG?
Correct. Yeah. On the phase 1 EEG, there were no right-sided interictals. But on the MEG, there were interictal dipoles on the right. That's correct.
Then you might say that MAG helped you in that case?
I think so. And this may be an issue of on meds versus off meds, right? I mean, in the EMU, they're off meds, and we saw the stuff on the left with the MEG as a ambulatory, study. They're on meds. Again, later on, when she had the RNS, she's on meds, and we saw with the important caveat that Jorge brought up, we saw only right-sided, almost only right-sided versus in the EMU, off meds for phase 1 and phase 2, it looked different.
Okay, we had a great 2 cases and a nice discussion. Anyone from the panel, or maybe Chima and Samir, would like to wrap up? And
so once again, thanks. Real pleasure and honor to present these cases. The presenting this case actually told me something in my practice that I hadn't thought about, the fact that there's a representation in pediatrics, and made me look around as to why that happens. But I think the key thing here, whenever one sees just MRI negative seizures and one thinks it sounds like temporal lobe seizures, I think we have to think about the possibility of a temporal plus epilepsy. There's no reason why cortical dysplasia has to be just temporal lobe, right? I mean, they don't respect boundaries. So one has to have that in mind, that you're dealing with more beyond that. And once again, thank you.
thank you so much, Chima. Samir, would you like to?
Sure. Yeah. Again, thanks a lot for the invitation. Really fun discussion. I think, we're seeing obviously MRI negative non-lesional cases more and more often, obviously. What do we do with that? As we've discussed, maybe a bit lower threshold now than there was before for intracranial verification of where things are coming from. And the case I presented was obviously not clear cut towards the end, but there's plenty of cases that are fairly clear cut that it's dominant temporal. And so in cases where you're not going to be able to do resection or ablation, which is obviously the first choice whenever you can, neuromodulation is becoming, more widely available, whether it's RNS, DBS combinations, et cetera.
Okay, I'd like to thank you. Thanks everybody for a great session. Hope to see you in our next one. I would like to kind of advertise that we are going to be having our next ESTM International Epilepsy Surgery Society meeting in Dubai in January. So please plan to be there. It's going to be a lot of discussions and fun in a beautiful place. And hope to see you soon in the next webinar. Thank you so much. And I will be opening the post-webinar link. Thank you.
Thank you. Bye-bye.
Thank you.
Thanks, Chima, Samir.
Thanks. Bye-bye.